And good afternoon, everyone. TJ Alds, I-45 Now, Galveston Now, and Clear Lake Now, bringing you another edition of Healthcare en Masse presented by UTMB Health. This being the month of October, though, it's going to be more than just a one show. We're going to have four shows where we delve into different factors within breast cancer. Obviously, October being Breast Cancer Awareness Month, and we are kicking this off with our first of four shows that we'll be doing this month. And we are so pleased to have on our guests with us here today. They include Dr. Kimberlyn Robinson. She's an OBGYN physician with UTMB Women's Healthcare Group, joining us here today. And then
Hi.
Dr. Angelica Robinson. So we have two Dr. Robinsons here with us here today, board certified radiologist and associate professor of radiology at University of Texas Medical Branch. And then we have another doctor with us here, but she's actually also a patient to be talking about breast cancer. And Dr. Martha Armstrong is on with us here and today, and we'll be talking about her recovery as well as the diagnosis as we go through the show today. So, doctors, thank you all for being on with us here today for the show for a very important topic. Indeed, we had a great conversation yesterday. As I had explained to Dr. Armstrong earlier, that learning more on this subject is something that everyone should do, and that's what we hope to do here with this. And let's get it kicked off though with I'm going to start with you first, Dr. Angelica. In the question I wanted to really get out there for you to do is that it comes down to that we hear about mammograms all the time, and when women should get mammograms and when they shouldn't be getting mammograms and how often and the like. And I just wanted to ask you, how often should women be getting mammograms?
So, the American College of Radiology and the Society of Breast Imaging recommend that women who are of an average risk, that is most women, would start receiving an annual mammogram starting at the age of 40. So, she would start at 40 years old and then she would have a mammogram each year. Now, that is going with the assumption that number one, she is not having any underlying problems. If someone is younger than 40 and has an abnormality in their breast, then they should come in before the age of 40. The other caveat is there are some patients that have a strong family history of breast cancer. And if they have a first degree relative, that would be a mother, sister, or daughter who was diagnosed with breast cancer at a younger age, meaning below 40, they would start 10 years earlier. So this is an example. Let's say that we have a patient and her mother was diagnosed with breast cancer at age 40. That patient would actually start getting annual mammograms 10 years earlier. So she would then start getting mammograms at age 30. But for average patients of an average risk for breast cancer, and that is most patients, the American College of Radiology and the Society of Breast Imaging recommend mammograms every year starting at the age of 40.
One of the things that'll come in is that folks are 40. That's awfully young, and that goes into kind of one of the myths that are out there. I'm too young to get breast cancer, but in all reality, that's where that number is important for more ways than one. And these are stats for the American Cancer Society. 1 in 6 breast cancers occur in women 40 to 49 years old. I think a lot of folks wouldn't, and you're the expert. You're the one that will see this firsthand when they come in for a mammogram. And talk about those risk factors and how important it is if you're coming in early and catching what possibly could be cancer or is cancer, because there is a difference between what may be cancer and what you look at, and then delving deeper and find that it is at that point.
Absolutely. So we know that breast cancer is more common the older that we get, but that does not negate our risk when we are younger. So we read the radiologist, the breast imaging radiologist at UTMB, we literally each read thousands and thousands of mammograms each year. And every single year, we do have patients who, on their first mammogram when they are 40 years old, we actually do detect a breast cancer. The point of screening mammography is to find the cancer early. So the statistics, have shown that breast cancer, you have an increased survivability when it is a lower stage. So what does stage mean? Stage is a fancy way for saying spread. So the goal of screening mammography is to find the breast cancer early. Our goal is to find it before you can feel anything, before there is a noticeable abnormality in the breast. This is why we want patients to start at the age of 40 and have that mammogram every year. Now with age, we do know, again, the risk of a patient getting breast cancer increases with age. But again, there are patients in their 40s who do have an unsuspected breast cancer. They're coming in for a screening exam. We find an abnormality, we perform a biopsy, and sometimes it is breast cancer.
One of the things of how important mammography is that when you go in for a mammogram, that it's helped reduce breast cancer deaths by a third since it became, I guess, the lack of a better term, a practice in 1990. And as someone who deals with this on the front line of that, at times, I should ask you is that there is a difference too. You have a screening exam and a diagnostic exam. Can you explain the difference of those so we
Sure.
can get a better understanding of that?
Absolutely. So, a screening mammogram, that is for a patient that is not having any breast abnormalities. So she says, I'm 40 or I'm 41, I have an exam every year. What do I mean by breast abnormalities? She is not feeling anything abnormal in her breast. She doesn't have any breast discharge. No one else, so another clinician didn't feel anything in her breast. Everything is quote unquote normal. She's just coming in for a screening exam. Now, that differs from a diagnostic exam. What does it mean when we say a patient needs a diagnostic exam? Well, what that means is this patient is having an abnormality. Perhaps they feel something in their breast. A clinician has felt something in their breast. They notice they're having breast discharge. Perhaps they're having breast pain. So it's a different exam that we do. Even though we are getting mammogram views, we are getting additional mammogram views. So it's not the same views we get with a screening mammogram. Also, if a patient is having a diagnostic exam, we may go on to adjunct studies. That would be, for example, a breast ultrasound. She may need eventually a breast biopsy, a breast MRI. So those are things that are considered diagnostic, whereas a screening examination is routine mammogram. We're getting standard views. She just comes in, comes out. She doesn't necessarily speak to the radiologist, and she goes about her day. Now, with that being said, a screening exam can lead to a diagnostic exam. So if on that screening exam we say, well, wait a minute, there is something here, and we call her back, and it can be also, let me say, it can also be him. Less than 1% of breast cancer is in males. So we do see male patients as well, but we don't do routine screening for male patients. But if someone comes in for a screening exam and an abnormality is detected, then when they come in for additional imaging, that would be considered a diagnostic exam.
One of the things I found fascinating talking with you in our pre-show meeting is the fact that this has become such a you're a specialist in this and in screening for breast cancer, and UTMB holds kind of a special designation too when you get a chance to talk about that. But something that I think debunked what a lot of folks may not realize is that if you want to get your mammograms, you don't have to call your doctor to get it scheduled. You can just go into a radiologist like yourself and say, I'd like to have a mammogram. Can you talk about that? Because I was not aware of that until you said so yesterday. And I should bring up my wife every year in October goes in to get her mammogram. And she always says to me, says, well, I need to call my doctor and schedule it up. And I was able to tell her last night, you don't have to do that. And she went, yes, I do. No, you don't. And even my wife was able to get that information. So thank you for that, by the way. I should just point out. But can you talk about, I don't know if a lot of people know that. And it was fascinating to me to hear how simple it really is to be able to get that exam.
Absolutely. So we don't want it to be a barrier to care that a patient has not seen her primary care physician or a clinician within the last year. So a patient can refer herself. What does that mean? It means she can simply call our access center, the UTMB Access Center. She can say that I am due for an annual screening mammogram. I haven't had one in over a year. I'm not having any current breast problems, and she can schedule that exam. Now, it is imperative that they are going to ask, who is your primary care physician? The reason she needs a physician or clinician on record is that those results need to go back to a clinician in addition to going to that patient. But she doesn't have to get an order for the screening mammogram. We don't want that to be a barrier. We realize that sometimes women, we have babies, and then we get out of that time frame in our life and we feel healthy. So we may not be going to a primary care clinician every year. We don't want that to stop your mammogram. We still want you to come in for your mammogram every year. In terms of the designation, the University of Texas Medical Branch Breast Imaging Center, both in League City and in Galveston, we are an American College of Radiology Breast Center of Excellence. What does that mean? That means that we have higher levels and standards as determined by the American College of Radiology. We specialize not only in mammography, we also do breast ultrasound, we do breast MRI, we do MRI guided biopsies, and we also have a team that we collaborate with for every single patient that's diagnosed with breast cancer. This multi-collaborative team is going to consist of our breast surgeons, our medical oncologists, our radiation oncologists. It is absolutely all hands on deck, a team approach. So we are looking at each individual patient, and we're each giving our level of professionalism and expertise and making sure that each patient gets the care that they need each and every time.
You're listening to Dr. Angelica Robinson. She is a board-certified radiologist and the associate professor of radiology at the University of Texas Medical Branch, and one of our guests on here today. And that was, you talked about that access center at UTMB Health, where you can get that number, 800-917-8906. That's open 24/7. That's UTMB Access Center. Just call, and if you're someone has not been able to, or had not was aware that if you're over 40, you need to, ladies, you need to be making call, and men, not necessarily for a mammogram. We talked about that, and that's going to be a topic we do have a little bit later. And one of the things that ties into this when we're talking about women's health is obviously probably a lot of times the most common physician, particularly for younger women they're seeing, is their OBGYN. And now joining us also is Dr. Kimberlyn Robinson. I should point out, a Ball High graduate, a local here. That is great. Go Tours. And great. So a local product here joining us. And Dr. Kimberlyn, thanks for coming on with us.
Thank you.
She, as I said, she is an OBGYN physician. And by the way, if she snoozes out on us at any time here, she's been up for 24 hours straight. During our pre-meeting yesterday, she was on the way to go deliver a baby.
That's it.
She's delivered. How many babies have you delivered in the last 24 hours?
4 babies yesterday.
Four
4
babies
last night. Yes. I wouldn't have it any other way, however.
What I have to, before we get into the topic of cancer, Dr. Kimberlyn, I have got to ask you, how thrilling is that to be able to bring in 4 new lives into the world over the last 24 hours?
It is one of the most amazing honors. It's such a blessing to be able to do. I love my patients. I love the babies. I love just, everything about being an OBGYN. It truly is. I would not pick anything else to do. I don't think Dr. Angel Robinson would say the same thing. I don't think that she would be happy to be in these shoes, but it truly is a life calling. It is definitely a calling on my life. My patients are like my family, and I just absolutely love being a part of such a special miracle and a moment in their lives. So it is awesome.
And already your fan club, Kia Henley, is in there. Dr. Kia, I'm so proud of you right there. Is chiming in. The moment you popped up, she sent that message on over there today. And as I said, Dr. Kimberlyn Robinson joining us now at OBGYN. And one of the things we talked about in our pre-meeting, and I wanted to address it here with both of you, Dr. Angelica Robinson, Dr. Kimberlyn Robinson, is that is the tie between women's health on the OBGYN side and of breast cancer. A lot, maybe some folks will say, well, OBGYN, that's taking care of babies, it's taking care of the lower part of the body and not thinking about breast cancer, right? But it does tie in, does it not, Dr. Kimberlyn?
It absolutely does. So, in our younger patient population, many times I am one of the only doctors that patients may see a year, being that either they're young or getting ready to have kids, or they're talking about contraceptive management, or they're talking about having problems with their menstrual cycle. So I may be the first step to get people leading into the right direction, and getting them referred for their mammogram. So they, typically we want you to come in yearly so that you can get your woman exam done at that time. You can talk to me about any concerns you may have about, your breast. You can also talk to me and, hey, what should I be looking for? We can talk about the signs and symptoms. I, prefer to see my patients yearly, so that way that we can get on the routine specifically about getting the mammograms done. But like Dr. Robinson said, they definitely can self-refer. And typically what they'll do is just place me as their doctor to have the results sent to. And then that way I'm in the loop as well, in that multifaceted kind of group approach to making sure the patient is being taken care of. But definitely it's the team approach. I have to call Dr. Robinson sometimes, hey, I'm worried about this patient. And, she gets on board and we talk about it and I get them referred over. So, it's integral part to work together as a team to get the patients taken care of.
And one of the things you brought it up, when you talk to your patients about what the signs or symptoms that be concerning for possible breast cancer, and we're going to bring up an infographic here that I think is so important for folks to see, is because one good phase is obviously when you're looking at things, the self-examination. We hear a lot about those, but can we just talk about some of those? What are those signs or symptoms that women particularly need to be looking for, that they should be constantly looking for to give themselves on alert?
Very good. So, like Dr. Robinson also said, a lot of times breast cancer, sometimes we don't know. And so that's the whole purpose of the screening mammogram. However, if you have a breast lump, right, a lot of times it's good for a clinician, be it an OBGYN, it could be your family practitioner, it could be your internal medicine doctor. Someone should examine the breast so that way we can give the radiology colleagues kind of a sense of what they should be looking for, or where they should be looking for, right? The location, which breast, but things that they should be looking for is there like a mass? So like a hard feeling in the breast, like, goodness, that wasn't there before. Wow, where did that come from? And so like a, hardening in the breast. So a little like what we call a mass. So there's something that is inside the breast tissue that is different from the surrounding breast tissue. The other thing would be nipple discharge, right? So that's something else to think about. And I don't know if it's on this picture, but is there something kind of leaking from the breast can also be a sign. If one breast is larger than the other breast, right? And that's a kind of a new finding for you, that God, this breast is all of a sudden larger than the other one, and it wasn't like that before. Skin changes to the breast. So is the breast a different color? Does it have an orange type appearance? Is there something going on with that? Now, that doesn't also necessarily always mean breast cancer, right? There's other things like infections and that kind of thing that can cause similar symptoms. But because the thing we worry about, of course, the most is a breast cancer diagnosis, then we want to make sure that we are looking for that as well. The other thing would be pain, right? So pain is another thing that can clue us in that something is going on. But sometimes the mass, you can have it and it may not be painful at all. It may be a painless mass in the breast. So that's the biggest thing. So, the breast tissue drains what we call the lymphatic drainage into the what we call the axilla, so under your arm. And so if you happen to be cleaning or, putting on the, or whatever it may be, and you feel something under the arm, that could be a lymph node that's swollen. So definitely if there's a swollen lymph node or something under the arm that you hadn't felt before in what we call the axillary region, then you should let us know that as well. And then another big thing is like a puckering inward of the nipple, right? So the nipple goes inward, and you had never had that before. Some people are congenitally, meaning born with nipples that are what we call inverted. So they're already inverted. But, typically we'd be concerned in that case because that person was born with that. But if this is a new thing where your nipple is becoming inverted, then that definitely would be a reason for us to see you. So, the biggest thing I want to tell patients is that if there is something that you are worried about, please do not feel like you are bothering us. That is what we are here for. That is when you need to make an appointment so that we can get you examined and get you over to Dr. Robinson and the crew over there.
And Dr. Kimberlyn, you bring up a point of, come see us.
Yeah.
That's the biggest step that
Yes.
anyone can make, is
Yes,
it not?
yes.
Is
Not
to
ignore it.
not
Yes.
ignore it. You mentioned about pain. It's the old doctor's tale of, if you feel pain, do something about it. Don't
Right.
ignore it ever.
Right. Yes.
Do something
Pain,
about it.
a mass, nipple discharge, any of it, please don't ignore it. I know there's a feeling of, oh God, if I just don't, go and see it, it's like it's not there, right? That is the thing. And I don't want people to do that, because, there are things that we can do specifically if we find it early enough. So please, 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 if I can't say anything more, today, if you don't take home anything else, is please be seen if there is something that you're worried about. The other thing I would say is definitely make sure you're getting your screening mammograms at 40. Earlier, of course, if you're having a higher risk of family history, but that would be something to discuss with your primary care doctor, be it an OBGYN or internal medicine or family medicine physician.
And again, Dr. Angelica Robinson's back with us as well. In that, I think too often, and particularly we'll talk about this in a little bit too, about COVID has come in and made folks understandably a little cautious, more so, but they're missing out on some care there. But it's that combination of, I heard a doctor once said that she had patients apologizing to her for bothering her for what they thought was something small, that as they kept checking it a little bit later, actually became something major. And how often, let me ask you both, Dr. Kimberlyn Robinson and Dr. Angelica Robinson, how often do you hear that your patients are actually like, well, sorry to bother you with this, but let me ask you. And then also too, I guess your response is, you're not bothering me at all.
Exactly. You're not bothering me at all. Please, please, please call me, because, the worst case thing for me to hear is that, oh, Dr. Robinson, I put this off for so long. Definitely come still, but I put this off for so long because I was scared. No, come so we can sit together, get through this together. So that way, we can catch it early and get all the people on board to help us.
Absolutely. I think it's important to note too, sometimes patients feel a lump and it is not painful. So for that specific reason, they say, oh, it must not be anything concerning. And that is not necessarily the case. So if they are feeling something, and the biggest thing is this a change? This is something new. There is a concept of what we call breast self-awareness. So what's normal for you. If this is a change for you, then we should further investigate. And I like to tell patients, there are, believe it or not, about 20 diagnoses you can have in the breast. People typically only care about one, okay? So, but there are 19 other things that you can potentially have in the breast. So it doesn't mean that it's going to be something bad. It could absolutely be something that you don't need to worry about. However, we need to see you so we can figure it out. But putting our head in the sand doesn't help. And I get it. COVID has increased the anxiety all the way around for everyone, for all of us. So I completely understand, but we still need you to come in, specifically with COVID, the COVID vaccine affecting mammography. So there's been a lot in the news. We know that the COVID vaccine is effective. We know that it can generate an immune response, meaning it's making your body build up a response so that the virus will not have the same effect as it would have had. That can make your lymph nodes enlarge. So Dr. Kimberlyn Robinson spoke about that earlier, the area under the arm, what we call the axilla. So we know that it can make the axillary lymph nodes enlarge. It's not concerning, but we know it can do that. Because we know it can do that, we are asking patients that if they have had the vaccine, the first dose, the second dose, or the booster, we would like for them to wait approximately 4 to 6 weeks, possibly a little longer, to delay their mammogram. Why? We are going to see those lymph nodes, And then we're going to have to decide, well, is this from the vaccine or is this from another cause, which is potentially concerning? Common things being common, if it happened right after the vaccine, it's probably from the vaccine. But it's easier if we can delay the mammogram. Now, with that being said, if she is having problems, but as Dr. Kimberlyn Robinson discussed, she's having discharge, she's having breast pain, her breast has gotten larger, then do not put it off. Then come in. But I'm saying for a routine screening mammogram, it would be ideal if patients can wait about 4 to 6 weeks after the last dose of their COVID vaccine.
And we should stress, as you had said early on in that explanation, it doesn't mean that there's anything alarming going on. It is to make sure you get the best diagnosis possible. And so to check that out, let me ask you on that line, though, you said of a waiting period there before you come in, is, if someone is gotten the vaccine, but they already have a history of finding lumps or having breast cancer in their family or them with themselves, like earlier on, should they be a little more concerned if they get the vaccine and see that swelling and just as a precaution to come in and check, or you still make the same recommendation to that patient as well?
If they're having any sort of other abnormality, they have a history of breast cancer, they have a family history, we would still evaluate. We would going back to what we talked about before in terms of a diagnostic exam. We would still do a diagnostic exam. We did diagnostic exams all the way through the COVID pandemic. We have never stopped doing diagnostic exams, meaning there is a problem, there is a change. We will get you in and we will do an exam. Now, sometimes patients need to know they'll have to be a bit patient. There's only so many of us, and there are a lot of them, and popularity is a good thing. So, but they may have to be a bit patient, but we will get you in. But if it's a new problem and they're having the lymph nodes and saying, but well, I had the vaccine, we can always err on the side of caution. We would rather get you in, evaluate, and go from there. But for a routine screening exam, it would be ideal if they can wait at least 4 to 6 weeks after the vaccine or the booster.
Speaking of popularity, Sherilyn Smith has got a hashtag already going for the two of you here.
Well,
Meet the Robinson doctors. I haven't had this much love for our guests. I'm gonna bring y'all on every week now. I got to tell you, we are joined by Dr. Kimberlyn Robinson, OBGYN at UTMB, and then Dr. Angelica Robinson, professor and also in radiologist for UTMB Health, and we're so glad to have you on our first of what's going to be 4 shows this month dealing with breast cancer. We mentioned about COVID, and I'm going to start with you first, Dr. Kimberlyn Robinson. Is how, because there's a kind of a tooth end of things with you. You've got patients coming in, who are pregnant. And this is a story we're actually doing a little bit later down the line. Let me ask you, because this has come up a lot, how many of your patients that are coming in that are pregnant are not vaccinated? And there was big news last week, or 2 weeks ago, I should say, was announced of that it's coming across to say, yes, it's safe to get the vaccine.
Yes,
I just want to make sure that we're hearing that from you here.
Yes, and yes, please get vaccinated. There are still some patients that, aren't comfortable getting vaccinated. Ultimately, my goal is to have as many people get vaccinated as we can, right? Because we all know the potentials that can happen when you're not vaccinated. With that being said, you support my patients the best way I can. I'm going to advocate for you on both sides of it. I'm going to sit with you and try to explain to you why. Ultimately, I expect or want you to have it. Ultimately, it is definitely a personal decision. I do not judge anyone if they decide that they don't want to have the vaccine. However, with that being said, I have just seen, and my colleagues have just seen so much heartache. Young parents are dying, leaving children. I have, patients that I know of, recently that have had, family members die that are very close to them. It's just really disheartening, to see people come in and have to tell you this person passed, or you get on Facebook and this other person passed. And so I just need all the patients to know, yes, it is safe in pregnancy. The College of Obstetrics and Gynecology does recommend that patients get it prior to pregnancy, during pregnancy, postpartum. Whenever you can get in there to get it is when we want you to have it done. This myth about infertility and the vaccine has been dispelled. There is no such concern there. The CDC actually also came out with a study saying that there is no higher risk of loss, right? Pregnancy loss. That's what everyone is concerned about. So I know this is a breast cancer discussion, but all of it kind of ties into our total.
And it goes into that kind of total wellness that we were talking about.
Total wellness, getting in to see Dr. Robinson, all the things. And COVID is a very big part of our lives. It's kind of put things on hold for so long. Patients have, unfortunately, at one point we were delaying well woman exams, delaying mammograms because of COVID, because just no one knew exactly what we were dealing with in terms of, making sure the healthcare workers were taken care of and all the patients were taken care of as well. And so there was a time there, people's mammograms kind of got a little delayed just by with COVID. Things are getting a little back, closer to some sense of normalcy. We're not definitely there. We're not out of the woods yet. So please don't think that. However, we are at a place where patients should be coming in for their well woman exams. We have this social distancing, and you should be trying to get your screening mammograms if you can, unless you had the vaccine recently, like Dr. Robinson said, to delay it a little bit.
And Dr. Angelica Robinson, we discussed this some yesterday, and I think it's important for folks to know too, because as Dr. Kimberlyn Robinson just pointed out, that there was a pause, I guess be the better term of it, until procedures are getting in place to be safe. What are the procedures in place? Because I think your best line yesterday was, "There's no social distancing in a mammogram."
That was a good line.
Yeah, that was a great line. But it comes down to as well, a concern. You've got to not only worry about the patient, you've always got to worry about staff as well. Just how safe is it to get a mammogram? And can you kind of explain to us what procedures are in place when they come in from a mammogram into your office and how that's handled?
Absolutely. So, number one, we are all masked. We are all masked. All of the staff and the faculty are masked, and we ask that all of our patients remain masked as well. We also do have distance within our waiting rooms, and we have extended our hours. We now offer some Saturday appointments as well. So we are trying to give patients a longer time frame so we can get patients in, but not having them all there at the same time. We are thoroughly cleaning each room, all of the machines between each patient, and we're making sure that we have enough time scheduled between each patient appointment to make sure that there is a thorough cleaning process. But is it safe to get a mammogram during a pandemic? Absolutely. So originally, as Dr. Kimberlyn Robinson alluded to, there was a brief moratorium nationally that was placed on screening mammography, never on diagnostic mammography. So if a patient had a problem, they were still coming in. But on screening mammograms, there was a brief national moratorium. Why? We needed time to change our practices. We needed time to change the waiting rooms. We needed time to educate ourselves, educate our faculty and staff. But now we are very confident that we are safely providing this service. We do not want any delay in care. So we want patients to come in and we want them to feel confident and know it is 100%. It is safe to get a mammogram during a pandemic.
You are watching Healthcare en Masse presented by UTMB Health. We are focused on breast cancer. This being October, we're going to have one show every single week through the month of October. We have joining us here today Dr. Angelica Robinson. She is a board-certified radiologist and associate professor of radiology at the University of Texas Medical Branch. And then also joining us is Dr. Kimberlyn Robinson, OBGYN physician with UTMB Women's Healthcare healthcare group, I should say, and has delivered 4 babies in the last 24 hours.
That's it, 4 babies.
I'm going to keep bringing that up every single time. I am, I haven't done 4 same things in the last 24 hours at all, and you've delivered 4 babies. I just don't know how you've done it. And as I said, we were on the line yesterday for our pre-meeting, and she's walking away with her cell phone, putting on the mask on her way to deliver a baby yesterday. That is dedication to be ready for the show today, Dr. Kimberlyn. I do appreciate the two of you coming on with us here today. Speaking of COVID and coming in for your exams, and we can talk about all the safety precautions that are in place, and those are in there. But one of the things, and we're seeing this across the board in all specialties, but in women's health, we need to stress that this month, I think, more than anything. Dr. Kimberlyn, if you can talk about, you even mentioned there's a patient you're somewhat concerned about. Obviously, we're not going to name that person, but that you haven't seen that would have been in, that there is a concern, because there are folks who are making decisions right now that are affecting other things because of what we've been dealing with COVID. And I wanted to start with you, Dr. Kimberlyn, and then go to you, Dr. Angelica, of talking on that subject.
Right. So, like she said, the brief pause that we had on things is I've had a couple of patients specifically that, didn't come in for their well woman exam, not by their own fault per se, but because things were placed on hold for well women, and we were only seeing people for problem visits, or in pregnancy for a little bit there. And so specific patient came in and was like, I was like, wow, I haven't seen you since 19. I was like, I know, this is not your fault. The pandemic has, put a halt on things for a while. And your last mammogram was in the 2019. And she's like, yeah, Dr. Robinson, I don't know. I just was, taking a shower and I felt this lump and it wasn't there before. Between the last mammogram and now, it's like, I just feel, so bad I didn't get my last one. And, I kept reiterating to her that definitely was not her fault, but definitely, I was able to palpate a mass and, I had to, call Dr. Robinson and say, hey, I know, things get a little busy, but can you please fit this patient in? I'm a little worried about her. So it's very unfortunate, for patients. We were all in this kind of gray zone of what to do. Do we go in? Do we not go in? And I just want to tell everyone, just don't fault yourself, if something was delayed, because at that point we were thinking, people were, dying, and still are, of COVID in large numbers. And so the fact that care was delayed is not your fault. You are seeking care now, and that is what matters.
And just as we have with everyone else, do not put off getting your care for everything else too. Yes. Make sure. And again, we'll put up for those that are UTMB patients, the Access Center open 24/7, 800-917-8906. Or if you're like me, go to my chart and just plug it in. That nothing better than at 2:00 in the morning making an appointment request.
Exactly.
You can do that then when you've had a busy day along the way. Dr. Angelica Robinson, let me ask you, I'm sure you have seen this as well, that there are some patients that you would see annually that have put off what would have been a kind of a routine stop in to see you at least once a year. And how is it a widespread problem? Is it improving at this point? I know in talking with a lot of cardiologists, they're telling me they're getting really concerned because it's growing, they think, in numbers of folks, and they just don't know why at this point. They're suspecting it's because of the pandemic, but I just wanted to get your take on that as well, what you're seeing.
It is improving. So we do have more patients now who feel comfortable and know that it is safe to come in and get the mammogram. I think something that I would really like to make sure everyone knows is that sometimes patients are delaying now because COVID has given them so much anxiety. They have so much anxiety, and they are truly, I have had patients say, if you find something on this mammogram, I just don't think I can deal with it. I cannot take one more thing in my life right now. So just please know that we will work with you. We understand the anxiety. We understand that this is not an easy time. It is not an easy time. We understand, we empathize, and we will definitely get through this. But you've got to come in. You've got to come in. So as long as you take that first step, then we will just go from there. And then what do we do next? We just take the next step. And then we take one more step after that.
I think it goes to what Dr. Kimberlyn said. It's a no judgment zone by the time they come see you.
That's it. Just get here.
Yeah,
That's
get
it.
there.
Just get here.
Deal with everything after that. It's about your health care at that point. And that's great. That does segue now to Dr. Kimberlyn. I'm gonna we'll have you back here in just a little while, but while we have Dr. Angelica Robinson on with us now, we're bringing on another doctor here, but Dr. Martha Armstrong now joining us. But she's on here for a different role. She as a patient, a breast cancer survivor as well. And Dr. Armstrong, thank you for coming on with us here today. And if that name is familiar to you, she is the better half of Dr. Robin Armstrong, local physician, and one of the great guys. I should point out, I've known him for many years and enjoy being around him. One of the smartest guys I know, and knew his father as well when he was on the Lamarck School Board for many years. Dr. Martha Armstrong, thank you for coming on with us. We appreciate you. Why don't you share your story about your journey with us? Because a lot of folks, I think it's a wonderful story of what you did, particularly being a physician yourself and having to deal with breast cancer.
So my journey with breast cancer began 3 days after my 42nd birthday. I was going in annually for my mammograms, didn't have family history, didn't have the lumps or the bumps in my breast. I had no signs of breast cancer, but I was going in for my annual breast mammogram, just like I preached to my patients. 3 days after I got my 3 days after my birthday, my 42nd birthday, I get a call from Dr. Angelica Robinson telling me there was, well, first of all, I had an abnormal mammogram. They told me I had to go in and get an additional views and a biopsy. So I did that. And then in October, I got a call from Dr. Angelica Robinson saying they had found breast cancer. And so totally caught by surprise. Like I said earlier, I had no family history and I felt I was healthy. Wasn't going to happen to me. So I was really fortunate. The fact that they caught it so early. Kudos to Dr. Angelica Robinson, who is like one of the best breast radiologists in the world. They were able to catch it really, really early. I was diagnosed at stage 1. I think if I would have waited till I had the lumps or the breast changes, it could have been pretty advanced. So it was so key for me to get that screening mammogram to catch it early and get treatment as early as possible. At that time, when I was 42, I had a 2-year-old, a 4-year-old, an 8-year-old, and a 10-year-old boys who I want to see get married. I want to see graduate from school. So it was really just important for me to get treatment and get this cancer behind me. It's been 8 years this October that I've been cancer-free, and I am so fortunate to be here to tell my story.
Yeah. Let's give a clap to that. And in fact, when you're talking about your boys, there's 2 of your boys right there. Yes. And you sent this photo, shared this photo with us. This is when you're in for one of your treatments, and you had said here, this is you explaining to them why you're hooked up to an IV. Yes. Let me ask you kind of the bigger question is that when you first got this diagnosis, what was your first reaction?
My first reaction was, I don't have time for this. I have 4 kids. I'm trying to raise a husband who's busy with this practice. I was really taken, surprised by it. I was like, okay, let's do what we need to do to get it, behind us, because I have to be around here for my boys. So it's just caught by surprise. And fortunate enough to have Dr. Angelica Robinson to walk me through the process. And like she said, no judgment. It was there. She was there to hold my hand, and she was there when we cried about the diagnosis, and fortunately enough, like I said, 8 years cancer-free.
And Dr. Angelica, this is not an isolated story here. Yes, you're a professional. You've got your job to do, but at the same time, you're also that conduit of compassion, empathy, sympathy sometimes, and you've seen the best and the worst of this disease. When Dr. Armstrong had come in, and I could tell the 2 of you have become fast friends for sure. That's for something else. I mean, I could tell the bond when we spoke all yesterday. Can you talk about when you heard Dr. Armstrong say, "I don't have time for this"? What was your reaction, and how did you handle that? Because I'm sure that's not she's not the only one that's had that. I don't have time to get sick. I don't have time for this. I have a life to live. I have kids to raise. I have a husband. I need to be a wife to, or a husband, a wife to a husband, and vice versa. How did you handle that to make sure, hey, this is not all is lost. We're going to get this done. Approach there, Dr. Robinson.
Yes, so it was. It can be. This is a part of the career path that is. It can be daunting. It can be daunting. So you realize that you are telling someone information that will completely change their life trajectory. So I always keep that in mind. I want to say we have a great team. I love the patients. I love who I work with, and I cannot take credit. Really, I truly feel to God be the glory for any ability that we have. And I have talked with patients. I've laughed with patients. I've cried with patients. But it's a journey we get through together. So telling Dr. Martha Armstrong, having her come in and saying, she had breast cancer. Yes, it was daunting. And I get it. I'm a mother of 3 kids, and she's a physician. She's busy. Her husband is a physician. And so I had 2 physicians coming to me and saying, what? So it was daunting. It can be daunting. She's in her, early 40s and really can't believe it. It was a complete shock, but it does happen. But she was so gracious, and her husband was like, we're going to fight. We're going to fight, and we're going to do this. And so you get the hope. The hope is restored. So the end of the story is not the breast cancer diagnosis. The story is the survival, is the fight, is the stories, is what we do after. So can it be shattering at the time? Yes, but we are all gracefully broken. And then we are rebuilt better, stronger. And I see the patients then the next year or just at the grocery store, and they are happy. They are living life. They are like, that was just a speed bump in my life. And I am now going on, and look at this, and look at my kids, and look at this. And that's what we want. She had a great story. Is every story great? This is medicine, but you've got to cheer when you have the wins, and it is a win because she's cancer free.
Speaking of the win, there's the moment she gets to celebrate with her family. Dr. Armstrong also sent us this photo with her family surrounding her here. I'm taking your husband, Robin, took this photo.
Yes.
He is an active photo guy. I will tell you that. I know this from a personal standpoint. But we showed the one moment where you're explaining to your boys. But let me ask you before we get to about this photo, that moment when you're sitting with your husband in the office, how important would you say it is? When you have a loved one with you, when you're getting this news, and then it's the next step, because it's one thing to get the news from Dr. Angelica Robinson about this. You've got to walk out that door at some point after you've gotten that news and go about your life. How important was that for you, Dr. Armstrong, to walk out knowing you had the support you did within your own family?
It's very, very crucial. I, as a doctor, I almost resorted to being to a patient. I told my husband, I was like, I need you to ask questions. I need you to take notes, because right now I'm just kind of just surviving. I didn't want to go into the medical part of it. I just wanted to just stay strong for my kids. I was like, I want you to answer the questions to make sure I get to the appointment. So he was with me the whole time, and just making sure that I had the support that I needed just to get better. My job was just to get better and go to my appointments. And so very, very crucial for me to have my family and my husband there with me.
That's tough, though, because I asked you the question yesterday when we were all together. So how bad of a patient were you? Because we always hear about doctors are the worst patients. It's when you said you assigned yourself to say, I'm a patient. I'm not a doctor right now.
Right.
Yes, you had that. That was important, is to understand you're dealing with a situation, but you got to move forward, and don't try to break it down in some medical journal.
Right.
Listen to, Dr. Angelica Robinson is our expert here. This is who's going to guide me. That's what
Right.
I'm going to do. I'm going to follow those guidelines. I'm going to talk to my oncologist. I'm going to go that route. Is that, I would take it, then that was what became your approach then?
For sure, for sure. And a lot of just self-care. There's a lot of well-meaning people that would come to you and tell you, well, maybe you shouldn't do the chemo because chemo is gonna, you're gonna lose your hair. You're gonna, at that point, it's like, I'm gonna do whatever my doctors and I decide is best for me, not what you think is best for me. There's gonna be a lot of patients, a lot of friends, well-meaning, are gonna say, maybe you should do more of the natural therapy. I'm thinking, I need to take the treatment that's going to increase my chances of being here in 20 years. So listening to your doctors, listening to your body, and getting the support that you need just to survive this. One of the things also, like Dr. Angelica said, was just this is not a deadly diagnosis like it was 30 years ago. The survival rate has increased. There's a lot of different treatment, not just chemotherapy. There's immunotherapy. There's anti-hormonal therapy. There's so much medicines out there that that's helping us beat this disease. But early detection is crucial. Catching it as early as possible is the key point that I want to stress as a patient. Getting those mammograms early and annually.
And Dr. Kimberlyn Robinson is back in here with us, and she was nodding her head to everything you were saying there, Dr. Armstrong, along the way here. We have about 9 minutes left here in the show. And again, if you have some questions, folks, feel free to send those over to us. We have more to ask. I must be doing a really good job because I'm getting the questions in, and we've had y'all's fan clubs show up here today that come along with that. Dr. Angelica Robinson, you said, we always focus on the one when we talk about an ailment within the breast. What are some of the others that you would say make the top 5 of those others that are there?
So the top 5 would be, there are benign, meaning non-cancerous masses that are in the breast, the most common being what we call a fibroadenoma. And the take-home point is it's not a cancer and it does not turn into a cancer. There are also patients that have cysts, and a cyst is a fluid-filled structure that is in the breast, also is not a cancer, does not turn into cancer, relatively common. Sometimes patients can have infections. So it could be where, and it doesn't have to be that they were breastfeeding or anything like that. Sometimes we see these infections are a bit more common in women who smoke. But with that being said, a woman can just be minding her own business and her breast starts turning red and it becomes infected. And when they ask about that, I say, well, it's no different than you can, get a cold. I mean, sometimes these things happen. So there are breast infections that patients can have. Also, sometimes patients will say, my breast feels different, but it could be that their weight has changed. So even 5 or 10 pounds up or down, that can change a cup size in the breast. So that is relatively common. And we will look with mammogram, also ultrasound. And often it's just a ridge of normal breast tissue, but it just feels a bit different because maybe their body habitus, again, smaller or larger, is different. So that can change that exam. And I don't want to leave our men out. So the most common abnormality with the man is what we call gynecomastia, fancy way of just saying increased tissue in the male breast. It can happen with normal hormonal changes with age, in the 18 to 28, 30, and then again in the 50, 60-ish range. Why? Because the body's hormones are changing. Sometimes it's a sign that there are other things in the body that are going on. Maybe there's a liver abnormality, maybe medications which are causing it, and so on and so forth. But again, it is typically, it does not turn into cancer. In most men with a palpable abnormality, it is typically gynecomastia. But we do each year diagnose a handful of breast cancer cases in men. About 1% or even less than 1% of all breast cancer cases diagnosed in the United States are diagnosed in men.
On that, and I just want to stay on the subject of men here real fast, is that there was a time, though, I know looking at statistically, that by the time a man was diagnosed with cancer, it was advanced stages almost always. Are you seeing more and more men now take it more seriously of coming in, even though it's still only 1% that are coming in, and at least when it's being caught, it's now being caught at an earlier stage?
Absolutely. So, and what that is just getting the information and doing this, putting the education out there. So, number one, it's nothing to be embarrassed about. So, if a man is feeling something, he often is embarrassed, and he's often thinking, I don't want to go. What are they going to even do? I mean, can they do a mammogram? The answer is yes. We can do mammograms on men. So, answer question number one. Question number two, is it going to be awkward? I don't want to be there with all women. What is that going to look like? We will sit you, in aside in a separate area, but we do need to evaluate. And there are many men, some famous men who have had breast cancer and who are very open about that diagnosis. So you're not alone. But it is in number two, the other thing to keep in mind is that if a man is diagnosed with breast cancer, we do know that other family members may have a higher risk of getting breast cancer if it was from a genetic mutation. So if a man is diagnosed with breast cancer, we are going to very carefully look at his children and make sure that they do not have an increased risk for breast cancer. So that's also something to keep in mind, even for patients, female patients who may say, to Martha's point, I'm not going to do anything. Even if this is a cancer, I'm not doing anything. That I completely understand. That's completely your right. But I would still say, I still recommend that we at least get the diagnosis because number one, to Dr. Martha's point, there are some oral medications that can be taken. So maybe we can start with that and go from there. But number two, even if a patient said, I am not going to do any therapy, no matter, even if this is a breast cancer, I will not do anything. Well, you can pass the information along to your children then.
Right.
So
Yeah,
at least your children, yes, know their family history and the medical history. So even if the patient says, I'm not going to do anything about it, I still recommend, well, we should probably still do the breast biopsy. Those are done in the office. You're not put to sleep. We have patients that go to work the same day. Usually it's the patients in medicine, Dr. Martha, who don't like to listen to our medical advice.
See, that's why I brought up the question about how good of a patient she was.
Exactly. But these are in-office procedures. And so we do the procedure in the office. You drive yourself there, drive yourself home. We'll have the answer from our colleagues in pathology. They're the ones that look under the microscope in 3 to 5 business days. And then they can tell us what's going on, and then decisions can be made from that point.
Dr. Armstrong, I'd forgotten to ask you because you had brought this up to me before we came on the air today. Is that you had already pointed out and talking about this, no family history. You had not had self-examination to come across anything, no pain or anything like that. But you said you did miss I don't know if it'd be a sign so much as
risk factor.
The risk factor.
Yes.
That when you look back on it, you realized I should have been paying more attention to this, right?
So yes, so my risk factor for breast cancer was, as a professional woman, I waited to have children into my 30s. So I had my first child in my 30s, and then I had my last son at age 39. So that exposure to the estrogen during my pregnancy was my risk factor. So as professional women, we have to realize that that is a risk factor, having our children later in age. That is something I had overlooked.
And well, thanks again for sharing your story. And back again to Dr. Angelica Robinson, we were bringing about men, and I to tell you the truth, up until this very moment when you said it, that men can have a mammogram, I had never thought of that. And I know this is the guy in me. I never thought about that because to this day, I remember, I'm going to date myself a little bit about this, when Richard Roundtree, the actor, better known as Shaft, Shaft, when he was diagnosed with breast cancer and the word gotten out, I don't think many folks had heard that about men at all. And it really got to me. I was like, oh my goodness. No, Shaft had breast cancer? No, there's no way. And but now that you've offered that, and again, I know this is the minute sale, but I'm going to call the Access Center, schedule up with you, and go through it. Is there any? I'm going to bring a camera in if that's all right. And Listen, I think
To
we
show
should
what
be
it's
encouraging.
like.
I'm not joking about this.
Yeah,
That
I
we
think
should
he's
encourage
serious,
guys
Angel.
to do this.
Yeah.
And again, I know normally it's not a routine thing, but we'll go if it's all right with you, we'll go a little outside of that, just so I can just debunk any concerns that men have as well.
Good. I like
I
it.
think that would be good.
Yeah.
You know,
Yes,
I got
we
my vaccines live on the air, and I got my booster live on the air. I've done many a thing. I had surgery one time live on the air, so we'll just do that and make sure. So get ready, Dr. Angelica Robinson. You're getting to get the phone call.
we have a great team. Our technologists are amazing, and yes, they can get a mammogram on a man. I've seen many a mammogram on a man, so they can get you. We can get that breast tissue in the machine.
Yeah, that's listening to my wife explain the process to me. It just I go, how do you do that? But hey, when you got experts like yourselves, that is great. And again, if you want more information on breast health, you can go to utmbhealth.com services/breast health/home. We'll have the link on the site. It's a little bit easier to just click on and go through there. And yeah, thanks, Sherilyn. Sherilyn's been our fan of the show here today. She's been our number one fan. Oh, and she's done another hashtag mammogram on a man. I think I'm going to hire Sherilyn now to just do our hashtags from it. I thought the best hashtag she said was the Dr. Robinson earlier, but now she's outdone herself here a little bit. I love her as a viewer now. I got to tell you. A reminder: this was the first of 4 shows. Next week, join us. We're going to have talking about breast cancer treatment. You had talked about that, Dr. Armstrong, about the different treatment plans there. Dr. Vicki Klimberg is going to be on with us talking about that. Then on the 20th, it's going to be surviving breast cancer, reconstruction, and patient support. Dr. Julie Park, and then patient Sharon Hillman Sharon Hillman will be on with us for that show on the 20th. And then on October 27th, connecting the dots between women's overall health and breast cancer. We'll have, and it's Dr. Jerome Yaklik. I've worked on that all day yesterday. Dr. Yaklik there, and Dr. Tanya Callender, who a close personal friend of my family's, and glad to have Tanya on with us, and that's coming up on the 27th. Before we wrap up here, I'll make the rounds here. Dr. Kimberlyn Robinson, our ball high grad. Oh, someone's coming in to tell you got another baby number 5 now. It's coming in. Any final words from you, ma'am, before we wrap up here today?
No, like I said, the biggest thing is, making sure you're getting your mammograms, making sure if you feel something, come in and see me, making sure you're getting all your care during the pandemic, just do so safely. And so that's all that I have on my end. I appreciate you having us all on today.
It's been wonderful. Thank y'all. Thank y'all so much, Kimberlyn. I appreciate it. And go tours. Yes. We got to make sure your ball high tours are doing well out there. I think my stingeries are still undefeated. I'm a Tech-State grad, obviously. We were having a hard time. I was giving her a hard time yesterday, and arch rivalry back in the day. Dr. Armstrong, any final word from you?
I think something that you guys said earlier about where you get your mammogram is really important. I was really fortunate that I had an amazing radiologist who specializes in mammogram reading. So not all radiologists are the same. So making sure you're getting a specialist who reads mammograms is very important.
And Dr. Angelica Robinson, you and I talked about this yesterday, is that given the status of the center and what you specialize in, you're going to have that kind of built-in institutional knowledge of what may be, and it's not knocking any other radiologists that are out there, but this is what you look for, and you're like, oh, this, we need to talk to you, because that's what happened with you, Dr. Armstrong, was we want to take a closer look here. And Dr. Robinson, you stressed that yesterday, that's an important factor here.
Absolutely. And I have an amazing team. I have wonderful breast imaging colleagues as well. We've all completed a breast imaging fellowship. That means we have done specialized training only in breast imaging. We are specialized. All we do all day long is breast imaging. So if you need a knee MRI, I am not the radiologist for that. But if you want a mammogram, me and my colleagues, Dr. Ann Lee, Dr. Flavia Postelman, they're all amazing. And I tell patients like, well, hey, who do you think I'd have to have me read my mammogram? I wouldn't read my own. So they're all amazing. But the final thought I want to say is that there is absolutely no judgment. Whenever you come, however you come, we will just go from there. We understand that life happens. Sometimes it's financial, sometimes it's anxiety, sometimes it's just a plethora of things, but there's absolutely no judgment. And the final take-home point for all of our survivors, for all of the women we've diagnosed, I just want them to know this: you did nothing wrong. You didn't do anything wrong. It's just something that happens sometimes, but you did not do anything wrong.
Wow. That got me too. I saw Dr. Kimberlyn reacting to that too.
That's a story for another day. We'll have to come back on and do that one.
Hey, I already told y'all yesterday. I had so much fun in the pre-meeting. I want y'all back as many times as we can. You particularly you two Robinsons, are y'all the hoots. If there ever was one.
She's the ringleader.
Yeah, I know. You kept deferring to her yesterday. But it's been fun. And Martha, say hello to your husband for me as well, would you? And the boys too. They're adorable. I still don't know how you wrangle them all. I tell you what, there's something else. So thank you all for coming on with us here. We do appreciate it. The information is on our site as well in the comment section. And again, a reminder, we will our next show is on the 13th at noon, breast cancer treatment with Dr. Vicky Klimberg coming on next week as well. Ladies, thank you all for coming on with us. We appreciate it.
Bye.
Drs. Robinsons
Bye.
and Dr. Armstrong, thank you all so much. I'm TJ Allens, I-45 now, Clear Lake now, and Galveston.